My name's Jenny Smith and I'm the CEO of the Council to Homeless Persons, and I'm absolutely delighted to welcome you to this National Homelessness Week event, which is the launch of the August 2021 edition of Parity, our national homelessness magazine entitled Every Grain of Sand, Preventing Homelessness Deaths. I'd like to begin by acknowledging the traditional custodians of all the lands around Australia upon which we're meeting this afternoon. I am here working from home in Wurundjeri country, people of the Kulin Nation, and I pay my respects to all elders past, present, emerging, and any who may be here with us this afternoon, and acknowledge that these lands, none of them were ever ceded. The work that underpins this edition of Parity can be seen in the August 2019 edition of Parity, The Last Mile of the Way, Homelessness, Death and Dying. And if you just look towards my ear, you can see it in the background there. That early edition features the initial work that Dr. Mark Furlong undertook for us, and it and the full report are available from CHP. We all know that people experiencing homelessness have a higher rate of mortality than the general population. And the key message from the 2019 piece of work that Mark did is that we just do not know the numbers of people who die prematurely as a consequence of their experience of homelessness. And the initial research underlined the point that to prevent premature deaths from homelessness, we need to have much better processes in place to allow us to know exactly what we're dealing with. And that need to know provided the rationale for this 2021 Preventing Homeless Deaths research project and the related Parity edition. Because to be able to argue for the policies and programs that we need that will help prevent premature deaths of people without a home, we need clarity about the numbers of those deaths and a greater understanding of the causes of those deaths. So the summary report of this second piece of research by Mark Furlong on preventing homelessness deaths is a feature of this edition of Parity, and we aim to publish and make available the full report as soon as we can. I'd like to thank our Parity editor, Noel Murray, who's probably in Darwin in shorts as we speak, for initiating this research and delivering yet another fine edition of Parity. And I'd like to particularly thank Andrew Edgar for his wonderful help in making sure today's event happened in Noel's virtual presence only. I think most of you know that Parity just couldn't happen without sponsorship, and so I really want to thank from my heart the edition's sponsors, the Salvation Army, Wintringham, Micah Projects, Sacred Heart Mission, Bolton Clark and Jesuit Social Services. And their representatives on the steering committee for this research project, chaired by Jane Barnes, Livia Carusi, Shane Austin, there you go, it's the end of Homelessness Week. You'll have to forgive me, Shane. Tracy Poore, Karen Walsh, Leanne Pappas, Karen Jelly, Jess Hurd, Jed Donahue and Brendan Fitzhenry. Today we're very fortunate to have with us Jason Clare, the Shadow Minister for Housing and Homelessness, to launch this important edition of Parity. Many of you will know that Jason is a member of the Australian Parliament, where he represents the sector of Flaxland in Western Sydney. Jason was a minister in both the Rudd and Gillard Labor governments, where he served as Minister for Home Affairs, Justice, for Defence and Cabinet Secretary. He also served as Shadow Minister for Communications, Trade and Investment and for Resources in Northern Australia. Jason is currently our Shadow Minister for Housing and Homelessness, as well as Shadow Minister for Regional Services, Territories and Local Government. Jason, it's great to have you with us. Over to you.
Thanks very much, Jen. I feel like a remote member of Parliament at the moment because I'm in lockdown here in Western Sydney, so I wasn't in Parliament physically this week. I was sitting here at the same desk I'm talking to you at from today, talking to the Parliament via video link. it does have its advantages. It means that when you get sick of hearing what someone's got to say, you can press the mute button. But I do feel like I'm a little bit disconnected from where the decision making happens, and I'm sure that everybody that's in lockdown at the moment, and I think about half the country is, must be feeling those pangs of disconnection and loneliness, and that is trivial compared to the pain that many people in our community are going through who can't work or are sick, let alone the people that we're talking about today who don't have a roof over their own head. So thank you for inviting me to be part of this launch. Jen, can I first start by thanking you for all the work that you've done this week in Homelessness Week. It's with everything that's going on around the country, it's hard to get public attention to focus on homelessness, on its causes, and on what we can do to eliminate it. But the work that you and your team have done this week has been enormous. And so can I, firstly thank you for everything that you're doing in shining a light on this extremely important topic. Can I, like Jen, start by acknowledging the traditional owners of the land on which we stand and their elders past and present and emerging. And like I did at the launch of Homelessness Week on Monday, make the point that you can't talk about homelessness without first saying 3% of Australians are Indigenous, but 20% of homeless Australians are Indigenous. That data should tell us that you can't have a serious conversation about homelessness without doing something serious about Indigenous homelessness. The Closing the Gap report came out yesterday. A good report, full of good things. It's got a target there for housing and homelessness, but no money invested there to do something about it. That's a big chasm in that report. Indigenous Australians aren't just overrepresented in our homelessness data, but more often than not, particularly in remote communities, live in some of the worst housing conditions, not just in the country, but in the world. And that should be a part of any serious discussion about what we do here. In launching this edition of Parity, can I thank you, Noel, for everything that you have done in putting this together, and the whole team and everybody that's contributed to this publication. It's an extraordinary publication, fantastic read. I came to this edition thinking that I knew what it was going to say, but got surprised by it. I started assuming, okay, well, we know that if you're homeless in Australia, you're going to die younger than most of the rest of Australia. And that's true. We work on the basis that the average homeless Australian or Australian experiencing homelessness is going to die 20 or 30 years younger than most Australians. And that shouldn't be a surprise. I think the paper put together by the team at Melbourne University and Monash University run through a cascading list of reasons why that's the case, whether it's interrelated morbidities, violence, victimisation, mental health problems, substance abuse, illness, injury, communicable and non-communicable disease, contact with the criminal justice system, or lack of access to regular preventative health care. All of that makes sense. But what surprised me when I was going through this publication was that that's pretty much all we know, that there's very little public health data that's available to help us better drill down and understand why this is the case. I think in Dave Pearson's piece that he's written with Shannon Valesi and Lisa Wood, he makes the point that we don't even measure mortality rates here in Australia. So that data point that I talked of a moment ago, that Australians experiencing homelessness will die 30 years younger than most other Australians, that's based on international evidence. That's not based on information that we've collected here in Australia. We don't measure life expectancy. I don't think we even measure the causes of death of people who experience homelessness. I was talking at the launch on Monday about hidden homelessness, about people who are sleeping in cars or on trains or couch surfing. This is not hidden homelessness. This is information that is invisible to public health research. Jenny and I were talking yesterday about this, and Jenny, you mentioned to me that documentation that's produced when someone dies, whether it's the death certificate or whether it's the data collected at the hospital, doesn't even mention if someone was experiencing homelessness at the time that they died. And there's no requirement for an autopsy if someone dies while experiencing homelessness. That paper that David, Shannon and Lisa wrote that I mentioned a moment ago tries to estimate how many Australians experiencing homelessness die in any given year, and they come up with the number of 424. And there's a section at the conclusion of their paper which I want to read out because it was one of the many things in this edition that grabbed my attention. It says this: imagine for a moment a plane crashing, killing 424 people, and the government admitting that they didn't know what caused the crash or investigating. I can stop there for a minute and think about that Malaysian plane that took off a couple of years ago, and we still haven't found where the plane crashed or how it crashed. But think of the hundreds of millions of dollars that have been invested trying to find an answer to that question. So let me go back and read this quote again. Imagine for a moment a plane crashing, killing 424 people, and the government admitting they didn't know what caused the crash or not even investigating it. Or imagine a terrorist attack that killed 424 people in Australia. A vivid imagination is not required to recognise that the reaction of governments would be swift. If 424 people died in any other circumstance other than dying because they were homeless and all of the associated things that impact their life because they're homeless, then the reaction from government would be totally different to what it is. But the fact that we have so little data to understand this, to measure it, to do something about it, I think explains why nothing does happen. What's that old saying that if you don't measure it, you don't do anything about it? Dave's paper makes the point that we don't have the data, that we need more data. We need more data. We also need more housing, more social housing. I can see Karen working away there. Karen's thinking in her head now, we need more supported housing. We need more supportive housing. I was up in Brisbane before lockdown. Karen and Micah took me around the work she does there, but in particular, we went to the Common Ground facility that was built about a decade ago in Brisbane and saw the work that Micah does providing health services to people that live at the Common Ground facility in Brisbane. It provides housing and health in the one place, a roof over your head and all of that associated health services on the ground floor. Dental, medical, I think mental health services as well. Karen, if I'm right, not if I'm on the money. And Karen gave me a report that Queensland University had done to assess the impact of that holistic approach to helping people who were chronic long-term rough sleepers in Brisbane. I don't have it at my fingertips, but my recollection is that that research showed a big drop in psychotic incidents, a big drop in hospitalisation rates, a big drop in people being admitted into the ICU or into emergency, big drop in interactions with police, big drop in arrests, big drop in court time. And what that paper, what that research from Queensland University showed was that if you get the model right, if you get the housing and the health services coming together, then you can save people's lives. People who live in that facility are alive today because of that service. But you also save money. Saves the health system money, saves the police and the courts money, saves taxpayers money. It goes to that argument that it costs more to do nothing about homelessness than to do something about it. So the takeout that I had from this edition of Parity is we need more data and we need more housing and the right type of housing. Just to wrap up, and I don't want to make it a sort of an ad for what we're proposing at the next election, but we've announced two big policies which go to some of what is in this report. One is the need for a national housing and homelessness plan. A lot of people have called for that. We've committed to doing that. What I got out of this report is that one of the things that that plan must commit to doing is filling this extraordinary chasm in the data set. The second thing we've committed to do is to build more social housing. You would have heard us talk about the Housing Australia Future Fund, a $10 billion fund to build 30,000 social and affordable housing properties over 5 years. And let me make it clear in my remarks here that that's not just any ordinary social housing. It's got to be a mix of housing that meets the different needs of different people. And that includes the type of housing that we built during the GFC, the type of housing that I just mentioned that Karen showed me through in Brisbane, that common ground type model, as well as the foyer model for young people. There is no one type of housing that is going to help everybody here. And that's why you need boutique different models if you're going to do what we all want to do, which is reduce homelessness and reduce avoidable death. So thanks very much, Jenny, and thanks everybody for the privilege to speak to you on a sunny Friday afternoon in lockdown here from Sydney. There are, I think, about 150 people here in Sydney who otherwise would be sleeping in a park tonight who are in hotel rooms. That's a good thing, but I fear that when lockdown ends, that shelter will end as well. We should be learning as we're going here. I fear that we're not. Census is next week. I fear that that data, when it eventually is pushed out, will tell us there are more homeless Australians. There are more Australians experiencing homelessness today than 5 years ago when it was last done. So our task is bigger. And the work in this report, I think, is very important in guiding the work that I would hope to do if we're fortunate enough to win the next election. Thanks very much.
Thanks, Jason. So thanks so much for being here with us today and for taking time out of your absolutely frantic schedule to so thoughtfully launch this edition of Parity. And it is wonderful for us as a sector to have you so engaged with homelessness policy, as you've demonstrated today, and in many ways championing the cause. And we look forward to continuing our conversations when you're Minister for Housing, particularly about how you can get Labor to pull out the big guns to fix the problems driving homelessness, particularly the levels of social housing and Centrelink incomes. But thanks so much for being here with us today. I'm now absolutely delighted to introduce Dr. Mark Furlong to you to speak to the research he's undertaken for Parity, setting the context for the panel to come. Mark's an independent scholar. In addition to more than 50 refereed papers, Mark's published 2 books, Resizing Psychology in Public Policy and in the Private Imagination, and Building the Client Relational Base, both of which you can see just over my shoulder in the bookcase behind me. Mark's practiced for many years in therapeutic and mental health settings, where he was a great boss to me for a while, and prior to that in positions at both La Trobe and Deakin universities. Over to you, Mark. You're on mute, Mark. You're still muted, Mark. Don't know whether Andrew can help you. There you go. There you go. You're
sorry,
right.
my mistake. Sorry for the lumpy things, folks. Thank you indeed, Jen, for that lovely introduction. And I'll try and do justice to the kind of things that you've introduced and Jason has introduced to us. It's been my good fortune to be the key labourer for this project, and it's been a really good project. But I must begin by again acknowledging the First Nations people, their leaders, past, present and emerging, and be clear that we are all sitting on lands that were never ceded. There's never been a treaty. Now, it's especially important, I think, to do that because I must say right at the outset that this project deliberately did not try and engage with representatives of First Nations people around this topic, premature death and homelessness, because there is nothing we could have done in the short period of time that we had to co-design a respectful process that could engage with something so profound as the dispossession, as the cartwheeling effects of colonisation that have resulted in the statistics and the human experience that Jason talked about earlier in relation to Aboriginal folk. So that's a very clear failure on our part. We could not do it well, so we didn't do it at all. We're very mindful that this means that there's a big gap in what we have produced. What I think we have produced, though, is an innovative action research project that has ended up with something to say about, well, what is going to make a difference to the shocking rate of premature mortality for people experiencing or who have experienced homelessness. And I'll cut right to the chase here. I mean, Jason and Jen have talked about some of the background that we're all familiar with. And we talked about this in our first report at some considerable length. The way that homelessness results in a 3 to 7-fold increase in the risk of early mortality. That, as Jason said, mortality is reduced, life expectancy rather, reduced by decades. I mean, this is a really shocking state of affairs. What our first report also was very clear about was the more recent research that has been mentioned already, that around 40% or thereabouts of deaths in the UK of people who are homeless are reported to be the result of treatable illnesses. Now, this should be a call to action, but in Australia, as we noted in our first report, and as several people have said already, we know very little about the facts and figures here in Australia, very little about the metrics. And why is that? Because the problem has not been recognised. International research is clear. We would expect the same thing to be the case here, but we haven't got good records. There are some good reports, but as an overall statement, it's fair to say we know very little about the actuality, the metrics of early death in Australia related to homelessness. And that question of recognition is going to be key in what I'm talking about with you today, what I want to present. So our report was, it had, well, the full report's about 90 pages, and as Jenny said before in that, we hope to have that out to people shortly, but the summary report is in this edition of Parity, and we have a fair to good description of what I'm going to leave out now, our approach. We had quite a multi-dimensional, quite a dynamic methodology. But what we really wanted to do in that was to hear from people who represent those with lived experience. We were able to, not as well as we would have liked, but we were able to hear what those representing people with lived experience have to say about what they think will make a difference. We also wanted to hear from, and we did hear from, representatives of those in and around homelessness. And that those consultations, there were 28, I think, we undertook, went from people like park rangers through to ED physicians. We spoke to people at multiple points in the specialist homeless services sector. We spoke to some very particular practitioners in relation to family violence, for instance. We also undertook a fairly solid lit review that built on the much more extensive search that we did for the 2019 project. We particularly looked at material that's come out in the last couple of years, and also material that was particular to what will make a difference, to what has been proven to be internationally useful in relation to minimising, preventing premature deaths. Now, this is ongoing work. We don't say we've summed it all up, but we have a fair grasp on the relevant literature. So what have we come up with in terms of the results of these inquiries? We came up with a number of, I think, important things. The first is around recognition. The second is what can be done about it. Mindful that action is based on recognition. If you don't recognise that there's a problem, you're not going to do much about it. So in relation to recognition, as Jason said, as Jenny said, we are clear that we don't know a whole lot about the stats, the statistics in Australia. Now, you can put that in a fairly arid way. It can sound almost desiccated, without life. The stats aren't there. Let's put it in another way. If we had a bunch of Olympians that died decades early, if we had a bunch of celebrities or even average persons, there would be, as Jason said, there would be real furor, there'd be real attention about that. In relation to people who experience homelessness or have experienced homelessness, they're not part of a high profile, high priority population group. You could almost say that they are rendered invisible, those deaths, by the way they're not counted. So why is that? Why is there this really stubborn absence of recognition? I'm going to just share a few overheads with you, and hopefully that'll become a bit clearer, because I think we've got something to say about why there is such a difficulty. Let's see if this comes up all right. I'm not sure if that's clear, but what we have here is we undertook a variety of different... Sorry?
It's fine.
It's fine. Oh, good on. Thanks, Jen. One of the points of interest, and Jason mentioned this, is what is happening in coroners' courts. As we, I think, generally all know, coroners' courts are a state-based institution, and we made an inquiry with the body, the national body, that collates statistics from each of the state coronial offices. And we paid our fee, and we received a report. Now, this slide is just one of the items we got back. So in relation to the question, deaths of homeless persons by year of notification, we were told that over a 5-year period, there were around 350 deaths. That's roughly 70 deaths a year over that period. If we say that Western Australia, Northern Territory, South Australia, Queensland and Tasmania are about 40% of the population of Australia, that means that there'd be about 30 deaths a year that get reported to coroners overall, and another 40 for Victoria and Western Australia. We think that's improbably low. We think that's likely to be very low. So we engage with discussions, dialogue with several coronial officers. And one of the things that we did with one of those officers was, what's happened here? I'm not sure what has happened there.
You're still on the table, Mark.
Yeah, I'm not sure what's happening. I might just call that off, Jen, and just speak to this, because there's something that's not right here. Yeah.
No worries.
Stop share. So can you see me now?
You're back.
Yeah. We made inquiries with one of the coronial officers, and they put in a proxy for homelessness. They recorded 8 deaths according to their recording system of people who were registered as homeless. By putting in a small correction of people who had known alias addresses, they used well-known welfare or homeless services in order to be seen to have a stable address. Those, by putting in that simple correction, it more than doubled the number they had. It went from 8 to 20. Now, we think this is only a very small percentage of the people that are homeless and who die who are picked up. So why do we say this? Because the scale of the invisibility is likely to be very high. Now, we know that from a whole lot of reasons, but one of the best local examples we saw at the Alfred Hospital, which is a metropolitan hospital here in Melbourne, they did a very thorough, very nimble study of the population that went through their emergency department. Lee et al. Was the study in 2019. And they found by a really persistent process of teasing out the actual residential status of people going through, that the hospital records missed roughly 9 out of 10 of the people that should have been registered as homeless. Now, this is I think, a fairly good indication. It's an order of magnitude indication of how much homelessness is missed. This is very salutary, and it goes to the point that if we look at the aggregate effects of homelessness not being rendered visible, we can kind of get an idea of that, because if you look at the national databases that record information about death, the national mortality data set, and there are 4 or 5 others. And I'm sorry I haven't got the slide working at the moment. I don't know what happened there, but there are 5 national bodies that we think are relevant here, and that not one of them devotes any particular attention to homelessness and early mortality. It's a shocking, I think, testament to the absence of attention to what is a low priority population group. The way that there is this invisibility is not just at the level of statistics, it's also at the level of, and I'm sorry if this sounds posh or pretentious, it's a level of discourse. If we look at, for instance, medico-legal convention, there's a convention of either declaring deaths due to natural causes or to preventable illness. That's what coronial officers do. And it's, I think, a reasonable point to say that this distinction between preventable and natural causes is something that could be challenged, because as soon as something is put forward as a preventable death, we need to do something about it. If it's assumed to be a death due to natural causes, well, those deaths just pass. We can't do anything about it. But the Eldridge study that was mentioned earlier, the one from the UK, about 40% of people who die who are homeless are dying from preventable illnesses. We would like to see that addressed in Australia. We'd like to see that question, what about doing some work with coronial investigations to see? Jason mentioned before about autopsies. We'd like to see some greater investigation. So if we did have more recognition, if we could get the action being undertaken to really properly document, to get the metrics on this, what could be done? Well, a number of things could be done. I've got 5 things I'm going to say here and that. At the level of the national databases, wouldn't it be good if the ABS published a bulletin each year that said this is what the stats are around homelessness and mortality? Wouldn't it be good if coronial officers were able to undertake, for instance, a dozen examinations, really detailed investigations of people who were recorded as homeless, and they might need to pursue their identification of homelessness more assertively? Wouldn't it be good if they reviewed, what seemed to be non-suspicious deaths that aren't either seen to be violent, unexpected, or accidental, to see whether there might be illnesses that could be treated with these deaths? In relation to health services, the health sector, mindful that most of the social determinants of health are not within the health system. A policy of inclusion health, development of hubs, step-down facilities, there are a range of things that could happen here. In relation to specialist homelessness services, and many of the people that would be part of this session today would know more about this than I would, but it could be that we perhaps could devote more attention to the assessment of risk of death. Now, perhaps that might for some people make it awkward. What is self-determination? What is duty of care? If somebody says, I don't want to talk about the risk of death, maybe that's something that we could engage with in a more nuanced way. But in relation to intersectorial work, I think the key thing that we could look at there is the exit to homelessness. There's some very powerful documentations of how people have died very quickly when they've exited, for instance, from a health service into homelessness without the kind of collaboration, the kind of coordination that might be involved. There are many other things that could be said there. And I'll just finish up by saying that I think this project, which has been a really fine project to be involved with, I've just had so much satisfaction and joy from working with the people I have been working with around, well, what can we do to do something about premature death and homelessness? Well, first of all, I think we can make it a kind of a tide. It's a good motif to be working for. It's something that I think would be something that maybe a working party and alliance of different groups, different agencies could work together on. And it's something I think might allow the public too, as well as perhaps politicians and senior bureaucrats. This is a galvanising call, a call to action. What can we do about premature death? And I think we can prevent that much more assertively than we're doing at the moment. So I'll hand back to you, Jenny. I'm sorry, folks, about the technical glitch here.
Many thanks, Mark. That was an excellent presentation, and congratulations from us on all the work that you've done in this space. And we know there's so much more for us all to do, but our appreciation for pulling it together in world record time and in the current difficult circumstances. So I can really commend to people the summary report that's in this edition, and do look out for the release of the full report. Now we now come to the panel event that will respond to the question, what is to be done to prevent homeless deaths? And this afternoon we have with us an absolutely fantastic panel of discussants, all with a range of expertise on the issues associated with the deaths of people without a home. We're very fortunate to have with us today to moderate the panel a long-time sector leader, Jane Barnes, and Jane is the Chief of Staff at Wintringham. She's a long-term CHP Board Director, and she chaired the steering committee for this research project. Now, in the interest of time, I'm going to introduce all of the panel members, and then it'll be over to Jane for the discussion. So we are lucky to have with us today Dr. Amanda Stafford, who's an emergency medicine specialist from Royal Perth Hospital, not lockdown, and the clinical lead for the hospital's homelessness team. And she's involved in homelessness policy and strategy initiatives at both local and state government levels, and in multiple homelessness collaborations in Perth. Also not locked down is Associate Professor Lisa Wood from the School of Population and Public Health at UWA. She's a tireless advocate for research being relevant and useful to the real world, and the need for academia to go beyond the ivory tower, and homelessness being a priority focus of her research and evidence-led advocacy over the last 5 years at least within Australia and internationally. Also lucky to have with us Karen Jelly, is the team coordinator at Bolton Clark Homeless Persons Program, which is a nationally leading program in the health space. She has over 20 years experience working for people without a home and other vulnerable community members, and she's particularly interested in health inequity and social determinants of health. We've got Tracy Parr in the Research and Evaluation Project Office at Sacred Heart Mission, where she supports measuring and understanding organisations' services and outcomes for people who access them. We've got Dr. Jed Donoghue, who's employed by the Salvation Army as a State Housing and Homelessness Manager in Tassie, and is currently acting as the Salvation Army's General Manager for Homelessness. And Karen Walsh, a woman who's everywhere, but she's the CEO of Micah Projects, which is a Brisbane not-for-profit organisation committed to social justice through service provision and advocacy to improve the lives of disadvantaged and marginalised people. And Mark Furlong, who you've just heard from, will also be on the panel. Over to you, Jane Barnes.
Oh, thank you, Jenny, for that very warm welcome. And thank you to our panellists who are joining us today. We've got about 45 minutes for this session. So the panellists have all been asked to keep it brief in the early stages. So they've got a maximum of 5 minutes. And hopefully that will then allow us time for some interaction with our audience. And please, there's in the chat function, please post any questions that you may have or that you may want to direct to any one of our speakers in that chat function. We'll do our best to get to them. And yeah, I mean, hopefully we'll get through all of them, but if we don't, we'll also try to follow up. We'll ask the relevant speaker if they could follow up. Okay, so given that we've got such short time, I'm going to go straight into it, and I am going to go over to Amanda Stafford, who's going to be our first speaker today.
So thank you very much for inviting me to be on the panel. I have an unusual perspective of both working frontline in an inner city hospital in Perth, in fact, our only inner city hospital, but also being very involved in homelessness work, both within the hospital and through a whole variety of collaborations. And when I think about preventable deaths, we see in this hospital about 11 people of no fixed address every day, and it represents about 4 to 5% of all our emergency department patients. And so that means that we're very exposed to homelessness on a daily basis. What's very obvious to me in the breadth of the work that I do is that our hospital system spends an enormous amount of money on people who experience homelessness because of the injuries and illnesses that bring them to the emergency department. But when I sit in community services meetings, what I see is penury, incredible limits on the money and therefore the services that are available, and also the astounding lack of social housing. And it's really about this money being spent in enormous amounts versus money which is not being spent, but it would cost. Would save the expensive systems a lot of money. And that's what I write about in the article that I wrote for Parity, is saying the myths we have about homelessness, such as that there's not enough money to fix the homeless problem, are completely bogus, because we spend on services such as healthcare, particularly hospitals, police, justice, prisons, foster care, etc. We spend vast amounts of money, and there's lots of evidence from different places which I present that tells you that that money is wasted because it fundamentally doesn't change the outcome for people. And so I think that there's really needs to be a shift in the paradigm to put money where it's actually going to have its best value, because we are not really looking at what value we're getting for our money. And this provides, I think, a very strong basis for pushing for a change in paradigm and pushing for a lot more funding to go towards our basic social safety net, which includes housing, income, supports, etc. And that would save our system and therefore taxpayers an awful lot of money. Very important, data is power, as my collaborators at UWA, Lisa Wood is here today. It is only by producing data, we've been doing that a lot, that you can present those arguments and that you can back them up. So I think I'll leave it there.
Thank you, Amanda, and really well done. Well done for time, but very and really interesting presentation. I'm going to throw straight to Lisa Wood now, keeping it in the West.
Good afternoon, everyone. It's a privilege to be here, but it's also what I call amongst our team our saddest part of research. And I think just to reiterate what Jason and others have said about the importance of really calling out the invisibility of homeless deaths and the role of data in that, and that's what we've attempted to do over here in WA, and with David made the estimate for Australia. We admit and we acknowledge in that paper that that's not a perfect estimate, but it's the best we have, and we have to start somewhere, because we count, you know, deaths in custody. AHW reports on deaths amongst people experiencing family domestic violence, deaths amongst shark bites, you name it. You know, we count all those things in Australia, and we don't count this. But I think the other thing I wanted to comment on just now is that what's also invisible is the human face of these deaths. And so the other piece that we have in Parity, myself and Shannon, from working in this area for 5 years, is really about the human face, and that each one is a life. And I just picked out one that I thought I'd mention here, because I work in a university. I teach a whole lot of health students, including for the last couple of years pharmacy students. And one of the case studies in our paper is someone who was doing pharmacy in his 20s. So it could have been any of my students. Schizophrenia, mental health that was poorly managed, kicked out of home, you know, the slippery slope into long-term homelessness and bouncing around the mental health system, and often the polarization between mental health and alcohol and drug use. Died at 46, and sadly died just a couple of weeks after being housed. And there's a really poignant piece in this special issue in Parity about the risks of premature death don't just end once you get a house, because often the chronic health conditions have already set in. The erosion of hope and all of that is still there. And so I think that's a really, so in our data here, we include people who may be in a house at the minute, but they've been recently homeless, because that's still taking its toll on this death. I think it's great that Mark mentioned the UK study about preventable deaths, which found that at least a third. We just in the nick of time, I was over in the UK last year, and we got rushed back to Perth because of COVID, but interesting talking to colleagues there who actually felt that that's a really conservative estimate, and I probably would agree, and particularly if we think about housing as one of the most fundamental ways to prevent deaths. But my broader work is in public health, and I think a lot of these, I think 5 of the deaths that we had in WA last year were cancers, including a really late stage lung cancer that the person had been on the street for 10 years. As Andrew Davies, our colleague, often says, you know, who could prep for a colonoscopy if you're living on the street? So I think in addition to what we can do in the homeless sector and what we have to do around housing, I think I'd like to issue the challenge for my public health colleagues around how we improve access for those preventive services and preventive care. And I think just to acknowledge also, I think there was mention from Mark and others around how do we build momentum for this. Under the umbrella of the Australian Alliance to End Homelessness, we have last year we started a Australian Housing, Homelessness and Health Network. So David Pearson has been leading that, but we're all kind of just volunteers, busy in our day jobs, but really trying to galvanise that linkage between health and homelessness and housing, and get traction both within the health sector and the homelessness sector. So if you're not signed up already, do so. Thank you.
Thanks, Lisa. And I see that David's popped a link in the chat for people to get onto in order to follow up on that offer around the health and homelessness and housing work that's being done there. Okay, our next speaker is Karen Jelly. Karen, over to you.
Thanks, Jane. Look, our program's been around for about 40 years. We're a assertive primary health outreach service in Melbourne. We cover a huge geographical area. And I think our program has always understood that there are systemic and structural underpinning reasons for people's poor health. And we know more recently from the evidence around the social determinants of health that people's health is really largely determined by social inequality. So the health inequality that people experience is determined by their social inequality. So when we look at people that are experiencing homelessness, they are extremely socially excluded, and they are impacted on by multiple social determinants of health. that are impacting on their life over their whole lifespan. So in our program, what we often see is by the time that people get referred to us, it's often later in their health trajectory. And we're seeing people that are prematurely aged, that are diagnosed with multiple chronic diseases, heart disease, lung disease, liver disease, cancers that largely could have been either preventable or much better managed. And I think we do know some of the things that do work to address these issues. We know that assertive outreach works. We know that housing first models are having an impact. We know that people can't address their health issues when they don't have stable housing. We know that flexible low barrier models work. We know that primary healthcare works for marginalised populations, and we know that people live in communities. They don't live in institutions. They live out in the communities, and in Melbourne that's spread over a very large area. So we need people to be able to access services in their local area, and we know that being able to access services isn't always going to solve their health issues as well. So we need to be working upstream, in an intersectoral way to address the things that are the root cause of people's health needs. And there's ways that we can be doing that. And I think we can do things in the short and intermediate term by housing people where we can, and by, working, for example, in health justice projects and other ways that we can work to address people's needs. But we really need to be doing early intervention to prevent people having these multiple impacts over their life and ending up prematurely dying. And we need to use those upstream measures as well. And I agree with everything that Amanda and Lisa and Mark have said so far. So I think I'll leave it there.
Great. Thank you, Karen. Moving straight in, I'm going into over to you now, Tracy. You're smiling, ready to go. So we're going really well for time.
Thanks, and hopefully I won't take up too much of it as well. So I'm from Sacred Heart Mission, and so in this Parity edition, there's just a little article, because when we asked some clients who stopped by at a hub or a residence at some of the accommodation sites, some really general questions as part of a survey. Multiple people told us that the services had health benefits and even saved their lives. So sometimes the comments were about being able to access health services or just getting a meal, sometimes feeling welcome and friendly sense of connection, and that welcome really shone through in stark contrast to appointments or eligibility criteria. And I think, people weren't just raising this because they knew that this is the narrative we want to hear, I suspect, because sometimes in the suggestions, not just the compliments, we see these connections that people made. And so I think it's a real moral obligation to take some of this small stuff seriously around just how challenging it can be to take care of yourself and do what you need to do when there are those barriers. And we know we have too many deaths. So at Sacred Heart Mission, the Journey to Social Inclusion phase 2 quantitative evaluation report that came out, I think, 2 years ago, it found the program works for providing an exit from chronic homelessness, but throughout it, the researchers have to adjust the counts for the people who died, because out of 179 participants, 13 died in 3 years, which is the same number that drifted out of the program for other or unknown reasons. So I don't mean to trivialize these sorts of terrible tragedies of people's lives being lost as they're, really engaging in quite an intensive program to try and have a long-term exit from homelessness. This isn't just something that inconveniences statistic orphans. Crunching outcomes data for us, the toll on the community is immense. And so many clients can tell us what helps them to be healthy and the actions they can take. And I think in Mark's research report, that's such a key part of the edition being launched today. That also features the voices of people speaking from lived experience in, some of these really practical things. Often when you go and ask people what will help, they say some of the most simple, cheapest interventions, and often it's just making things just that tiny bit easier. But we know the physical toll of it all is also immense on the people who live through homelessness. And, the premature aging we see means, yes, many of the people we hear from and meet at Sacred Heart Mission, as I'm sure a lot of us meet in other parts of our lives in the community, they do need specialised health responses that others their age might be much less likely to need. And these need to be accessible, which I suspect means people are welcome and feel welcome. Otherwise, they're just not going to get that response. And so I think, you know, anything we do to make it easier for people to keep living is probably going to help. And it's, you know, it's not going to be the answer to everything. But thanks.
Thank you. Thank you, Tracy. I'm going to move now to Karen Walsh.
Hi, everybody. I'm speaking to you from Queensland on Jaguar and Turrbal land, and I'd like to acknowledge the traditional owners and acknowledge the overrepresentation of Indigenous people in our homeless services and experiencing homelessness. We know that it's up to 28% at times, so the number of people who are dying from preventable illnesses from Indigenous communities is equally as high, but of course we don't have the specific data to quantify that all the time. Look, most of the things that I've reflected on have already been said by different people, and I think that it's great that we're in a position where we can just pay attention to deaths, because, you know, we know so many people living in homeless, they feel their life is invisible, and it's also, you know, we don't want to make sure their deaths aren't invisible as well. And it really means that we've got to take a different look at how systems record, which Mark pointed out and which the broader report will speak to, but how we actually do identify and how people's death is recorded is such an important issue, especially when we look at those issues around the addresses that people put in hospitals, that it went from having 8 to 20. You know, in Perth, I mean, you're leading the way in terms of how hospitals can look at identifying who is homeless and within the system, and then linking up. So it's so much collaborative work with the community sector. I think every state's got beginnings of that, but we need it to be much greater scale. I know for us last year, we had 15 deaths among the population we worked with and the participants of our services. And this year we're at 5 already. I also think that the skills that we observe every day in the management of COVID by applying a public health response are skills that we could apply to tracking and really looking at the experience of people with homelessness as a public health issue, which a lot of people do call for. And if we did that, well, then we would track much more clearly the diseases, the reasons people are dying prematurely, the lack of screening for cancer, for example. We know that many people get diagnosed in prison, but it's too late when they're coming out, they're in their palliative stages. Many people on the streets get diagnosed with very, you know, close to death rather than ever being in a position to even think about what treatment they might be able to have in relation to their cancer. And we know that you know, over 70% of the people that we had worked with last year have comorbidities of chronic disease, mental health diagnoses, and substance use. And they're not all in this equal proportion, but those 3 elements are there impacting on their health. And then you compound that with the social determinants of health, of lack of food, lack of proper housing. You know, many people are living, I mean, yesterday we were asked to accommodate a family who had, you know, are living with 3 pet children with a disability. The toilet doesn't work, the water is blocked, plumbing is blocked, and somehow she had signed a lease that wasn't really a lease to say that she wouldn't sue them if anyone was injured, was how the landlord approached it. And we know we've got multiple examples of situations that people are living in and where their health conditions are made worse, or they become ill because of living in those circumstances. So I think that we should really, keep working and calling for research. We need academic institutions and other health institutions to really look at, what is the trajectory, how can we improve to a more accurate count, and how can we show that we are really concerned about every citizen in Australia, both while they're living and when they die. Thank you.
Thanks, Karen. Okay, our final speaker today is Jed Donoghue, so I'm going to throw to you now, Jed.
Thank you, Jane. The panel discussion can often be like a penalty shootout, but I feel all my colleagues have hit the mark, so I'll try to follow suit. As this is a personal reflection, I will also be using the I word, so I just want to start with that warning, but I've only got 3 points to make. Initially, I thought that this issue of parity would be confronting due to the nature of the subject. Many of us avoid talking about death, especially as we get older. But now I know that the subject matter is not only confronting, it's unacceptable, from what I've heard. It's unacceptable that people die prematurely in this country. My second point is that initially I wondered how many people are forced into homelessness, who have been forced into homelessness, have been affected by premature death. Not just the individuals who've died, but also their family and friends. And after listening to the discussion, now I realize that too many people have died due to something that could have been prevented. Yeah. My final point. Initially, like many other people, I wondered what research has been undertaken on this issue in Australia. And I think now we all know that this is a hidden topic. It's been ignored for too long, and it needs to be addressed. Once we know there is a problem, it's time to do something about it so that it can be stopped. But I'm not going to ask for somebody else to be a champion. I'm going to ask for all the participants here to be the champion, to keep this on the agenda, and to do something about it. Thank you.
Thank you, Jed. I think you've just given my nice summary for me. Look, thank you to all our speakers, and I think that, as Jed has just kind of said, you've given us a whole lot of food for thought, a bit increased our awareness of what is going on. And I have to say, I'm really heartened. I think since the first edition of Parity that focused on deaths in 2019, I think it was, we're now doing a lot of work around the country, and I do find that heartening. What I find disheartening is how much more there is to do. But it is really good to see that we have got, even just here on the panel, but certainly in our audience today, representatives from practitioners, from academics, from the health provider systems, and we even had a politician involved saying that he was interested in it too. And as Jed said, we do need to all move together in order to address this issue. I guess leading now into some questions, and I'd really encourage the audience to put some questions to this panel. That there's clearly quite a bit of work going on. That certainly, from my perspective, until I read the articles coming into this Parity, I had no idea, and the work that we did in the working group, no idea how much was going on, particularly in Perth. And it's really, really fantastic, and I think we can all learn from what you guys are doing over there. But I'm gonna open the discussion and the questions. I'm going to throw to Mark, bring you into the panel. Mark, you talked about that we need more data, but one of the things that you talked about, and we need better understanding of it. You talked about this in your research as well, that too often death can be regarded as a natural event, an act of God, or hidden, if you like, by natural causes. And so I guess I put to you, how can we challenge that? Do you think we can change that, and how could we do that?
Thanks, Jane. I think there is and I touched on this just a little bit before, but I welcome the chance to expand on it. There is a narrative switch point. There's a kind of a choice point, if you like, between natural deaths and deaths that we can do something about. So, as you're saying, I reckon that we can challenge that by, first of all, pointing out the number of people have spoken about the UK research that says that 40% or so, and Lisa was saying that might be a conservative estimate, of deaths are preventable. Now, Jenny Hutton and her colleagues at St Vincent's in Melbourne, I believe, are very close to doing or finalising a report that seeks to replicate the Eldridge study. So that is potentially something that could be a spark to, as you say, challenge the dichotomy, oh, they can't be helped, they've just passed on, it's a natural cause death. If we can have some local stats that do very directly say, hey, that's not true. But it's also possible that we can tickle that along with various, call them service development or service improvement, quality assurance exercises with coroners' courts. For instance, this might sound odd, but the Australian and New Zealand coroners have an annual conference. Wouldn't it be good to have some discussion at those conferences about how that particular distinction is gated? I mean, the idea that we have this custom where deaths are regarded as needing to be reviewed if they are either accidental, unexpected, or violent. Well, what's unexpected mean? Couldn't that be a very particular way of beginning to deconstruct this old custom of, oh, we don't need to worry about those? There's lots of parts to it, but I think those two things are, for me, important, that we can really use some local research that's not just from somewhere else, it's from here, it's from a reputable place here. And also we can try and find some points of contention where this is actually hitting the road. I mean, the voice of authority really, in naming something as a natural death as opposed to a preventable death, that's about words having consequences and being able to challenge the basis of assumed practice, of customary practice around this and that is potentially quite a powerful intervention.
Thank you. Anybody else with a view on well, particularly when Mark's talking about we need more research, I'm interested in any of the others, if you have anything to say about that, and if so, what that next step research might be. Yeah, Mark, I'll let Lisa have a go first if I can.
Yeah, sure.
Just to comment, so this is something that David, Shannon and myself thought about in the paper we put in, and I guess it's great if, you know, different ones of us around the country are doing our own bits of research, but I think what we would love to see, and we've called for in that paper, is that it actually gets taken on board by the Australian Institute of Health and Welfare in the same way that they do these lovely reports that are really handy for research about the health of Australians, and it's just missing in there. But there's stuff in there about disparities in deaths by geography, by socioeconomic status. As I meant, even now talking about, you know, veterans' deaths and things get mentioned, but a really vulnerable group is missing there. So I think there's things that we can be doing at our own individual and state level, but I think we would love to see more people really, and maybe this is where Jason can help with the advocacy as well, about saying it should be recognised if we're reporting on Australia's health, then it needs to be there. And yes, there's lots of kind of challenges around the data, but I think if someone like the AHW gets behind it, then that means there will be greater compulsion for hospitals and prisons and other services to improve their recognition of who's homeless, and then also that has implications for what Mark's mentioned about the coroners and so on. So aim high, but keep doing it locally, I think.
Can I say something very quickly, Jane? It's following up from what Lisa's saying. We've also got in our report, we had contact with Nikki at the Australian Institute of Health and Welfare, who looks after the homelessness stats. Now, also housed within the Australian Institute of Health and Welfare is a national mortality data set. Now, it's possible to do a data matching exercise between those two bodies of data. Now, that requires a particular formal research project, but we've been told that that is possible to do. Now, mindful, the SHS data doesn't capture anything like all of homelessness, but if it's clear it captures a fair whack, we would have a very substantial contribution to what we know about homelessness and its relationship to mortality if those two data sets were matched. So I think, Lisa, that's something that is not just a maybe, that's a real possibility right now.
Thanks, Mark. Karen Walsh, were you looking to say something?
I was just going to say that our know by name lists are being useful in talking to practitioners and workers, you know, to record when we know deaths happen, but also that any research we do, we need to not just end it when people are homeless. It's really about health inequality and that journey from being homeless, which is creating such an impact on their health. But some people die very soon after they're housed, and we would need to be able to capture that, particularly because if we're advocating, we advocate strongly for people to have a home so they don't actually die on the street. And we've had people who want to stay on the street because they're worried they'll die at home and no one will know, from a diabetic coma or something. So I think, you know, that's the sort of work we could do in working with practice and researchers about that journey and how we would look at mortality as well as death, you know, the link between homelessness and the age of which people die, not just whilst homeless, but also when they're housed. But also I just wanted to say, being Homeless Week, that we should really put a shout out to all our workers in specialist homeless services who show enormous compassion to people while they're dying. It's not part of their job description. It's not part of something that, you know, they expect to happen, but it happens quite frequently. And I know lots of workers who just go that extra mile to do the little things that people might want to have done, whether it's a phone call to a family member, making sure we record what we do. And I think that so many homeless workers just show enormous compassion when dealing with death in our homelessness context.
Thanks, Karen. Did anybody else want to have a go at where to connect this with research? Because if not, we've got a question in the chat from Brendan, who's asking if it is possible to identify and work with the triaging points on reportable death decision making for specific intervention of an activist nature. Someone want to have a go at that? Thank you, Amanda. So
from a hospital and emergency department, so a lot of point of view where a lot of deaths that occur on the streets would happen. So the triaging points for whether we consider a death to be reportable or not, which is the specific involvement of the coroner. So it's around certain characteristics of, do they have a known disease which is proven to have caused that particular death? The issue of their homelessness is not part of that, although we are less likely to know about their medical conditions if they have had very little contact with medical systems. They don't have a regular GP. or they've not been seen at a hospital. So I think the trigger points, the triaging points about reportable death are really set in legislation. So there are specific ones such as inpatients in a mental health unit, following the birth of a child. There are some conditions which mandate the involvement of the coroner, but you would have to go back to what is actually mandated. So it's not generally a individual decision. It's usually based on the legislation, as somebody who has to do that quite often.
Mark?
Just following up what Amanda's saying, there's multiple points where this is routinized in some ways, as well as carefully thought through. For example, speaking to one of the senior pathologists at one of the state coronial offices, that person, she or he, we were very clear that we weren't going to make any of our material identifiable in any way. That person was really clear that there are customary practices and that the inquisitorial role that a coroner has potentially, that it's not, as probably well understood, it's not an adversarial judicial service. The coronial process is one where there is a lot of ambit that a coroner can initiate to investigate the circumstances, including the psychosocial circumstances surrounding a death. So the point that Amanda's talking about, whether it's reported, is one of the customary things. That yes, there are mandatory things in terms of legislation around if somebody's in care, for instance, the things that Amanda was saying, but there's also habituated practices at different points. Like a lot of deaths aren't reportable because there's seen to be, well, somebody's got an illness. But that doesn't necessarily mean that we have a full understanding of has that illness been able to be treated as well as it could have been, for instance. So if there was an open-ended investigation at the coroner's end, it might lead to a very different understanding of not just the immediate cause of death or the kind of the focus, the immediate focus. It could also lead to a broader understanding of the trajectory that led to that point. So that's something that coronial services could theoretically be more involved with.
I think they could theoretically. The difficulty is that they receive an enormous number of cases referred to them, and they actually try to minimise the number that they really need to investigate. So they'd probably have to have a special project around that.
Thanks, Amanda. I think that goes some way to Kate Rice popped a question in there about, is there anything that that practitioners or people that, you know, who are submitting paperwork for a coroner's investigation or report, is there any, have you got any tricks? Is there anything that we can do to really highlight, you know, the person's extensive history of homelessness, or no?
No, and the reason is because basically you're saying we don't know what the cause of death was, and therefore we're referring it to the coroner for investigation. And so it's the coronial office and the police that are expected to do that investigation. It's hands off for us. We're not expected to try and work out what's there. So they would be very surprised if we started to say, well, we want you to investigate this because, and we want you to take special attention. I think we would just be politely told to do our job and they'll do theirs. Yeah, there's no input in terms of what we think might have caused it.
So there's a question from Brian Littman in the panel, and he's kind of stolen where I was going at the end there, Brian, so good on you. Yeah, clearly the aged care system has got a lot to learn about working with people who have prematurely aged as a result of extreme lifestyle circumstances, homelessness, but you know, at Wintringham every day we see people, and we have a lot of people in our services who have got those histories, and there are there's so much evidence walking around the services about what good quality interventions, can achieve. I think, Karen, when you said earlier that sometimes people die not long after moving into their own home, that's very, very true. But I think that, there are equally the positive signs about people who may well have significant impacts on their health and have signs of premature aging, but that we can stall those signs, and we can make an impact. And I guess that in a way is really what a lot of today is about, is, how do we prevent premature deaths? How do we prevent deaths? But particularly, how do we prevent, our premature aging? So I guess we've got a couple more minutes, and I would like to go around each of you, and I just want to pretty much ask you if you had a couple of top ticket items, or even just one. What do you think is the number one thing that we should be pushing? What could be done? What's the most important thing to prevent homelessness related deaths? All right, and I'm going to start with you, Jed.
Well, the diplomatic response would be, we need more Wintringhams, Jane. But prevention is something that we don't do well, I think, in Australia. I think we tend to wait for people to be in trouble before we offer assistance, for a number of reasons. But yeah, prevention is better than the cure, isn't it? As it flows off the tongue. It's a difficult one though, because it doesn't seem to be, because we are so hooked up, we are so connected to dealing with trying to get people housed, that we don't have a lot of space to actually keep them housed or prevent them losing their housing. And that's where the resources are going at the moment. So it's either we reprioritize our existing resources or we get more to do that work.
Thank you. Tracy, your turn.
Thanks. Yeah, I guess picking up on that, maybe being able to, intervene really early in crisis. Like, we talk a lot about early intervention around avoiding entry into the homeless service, but if somebody is housed and they're, experiencing a crisis, making sure that those resources are there. And if somebody, is at that point of being in a hospital emergency department, like, those responses need to be in there. And I think that, an RMI Uhuru report that came out a couple of weeks ago sort of really pointed to, people leaving residential settings into homelessness because they lost housing while they were there, or they're already homeless. Like, those sorts of links between systems, that's a system issue. And I think we need to look more at the person.
Thank you. Karen Jelly?
I think, look, a better understanding of the social determinants of health. The same drivers that are the social determinants of health are the same drivers of homelessness. We know family violence is the biggest factor driving homelessness, and it's also a big determinant of health. So there's a lot of matching, and we need to just move forward with addressing those determinants of health. And I noticed Shane just put a comment in the comments there as well about the role of the SHS, and I think that early prevention, and I think a lot of the people that we see have a disability, and it's often not recognised. And I'm talking particularly about acquired brain injury and traumatic brain injury, and the things that occur with a brain injury, like impulsiveness, difficulty planning, all of those sorts of things are things that make it very difficult for people to manage their health. So I think early intervention and good assessment initially when people are presenting at access points.
Thank you. Amanda?
So the number one is, for me, is simply housing, sufficient social housing until there are no waiting lists. I mean, because if you always have waiting lists, and we have an enormous one in WA, you cannot house people if you don't have available housing. And it's very binary. You're either housed or you're homeless. And so things like the other two things that for me are very important are having the right supports for that person. And the third one is having long-term GP care, so good primary care. But the rest of it is, even those two, the supports and the GP care, have minimal real progress for someone, particularly in terms of preventing early deaths, if you're not housed. And I think that, yeah, for me, the thing that tells you you've got enough is that you have no waiting list. Because at the moment, everything is done from a place of penury. There's never enough, and waiting lists are used to manage demand.
Thank you. Karen Walsh.
I think we have to see housing as a platform to embed healthcare and community services. And whether that housing is in the form of aged care or whatever secure tenure that's appropriate to the age and personal circumstances of every individual or family. But we need to work, you know, for the percentage of people, like there are lots of people that just need affordable housing, but for the percentage of people that are experiencing significant health and personal issues, I think that housing is the platform that you embed that healthcare and you embed community services, because we've got to break down the silos. Like, you know, we can't, even in health, you can't have someone who just looks at someone's cancer and, you know, palliative care and isn't looking at how they're managing their diabetes in the same week. You know, like we had 3 health professionals around one person recently. And you know, they say the same thing, you know, how do we actually bring it together so the silos are gone, the quality of life is improved. And Amanda, you said it at the beginning, make sure the investment is placed where you get the outcomes, not where the system just is unwilling to change.
Sure. Okay, we've got a couple more minutes. So Lisa, go from you.
So we know that the longer people are homeless, the more the risk of premature death. And so I'm just wondering from an advocacy point of view, so there's lots of momentum building and continuing to build around the country around the lack of affordable housing, lack of social housing, the wait lists in multiple states, not just our own. And now I feel like we've got this, you know, there's been quite a bit of media this week about the deaths, and that's an advocacy opportunity. And I just think that we could actually leverage those off each other. I got asked by a member of parliament yesterday if I could hand over the list of WA deaths so that he could check how many are on the social housing wait list. So obviously I said that's not possible, but it's a really good question, and we know some of them are. So I think this thing of how long people have been bouncing around in homelessness, and including people that might have, I mean, our government has said, oh, but that person was housed back in 2005 and then they lost their tenancy, and, you know, so that's it, you know. So I feel like that perhaps we can harness these two things together, so that when we're talking, if we're going to do some more advocacy around the deaths, some of that stuff around how long those people have been homeless. And we've got one of our case studies in the Parity, homeless for 3/4 of his life, from the age of 8 when he was abandoned by his family. It's a patient Amanda knows. So I think there could be some traction there around linking that with the housing argument.
Absolutely. And Mark, last word.
You've all heard too much of me already. So really simply 2 things, and they're complementary. It's not what's on the podium at number 1 or number 2, number 3, but recognition begets action. So the ways that we can build up the recognition of this problem, and there's multiple layers to that, and we've talked about those. But I just want to say one of the things that I think is limiting recognition is the very understandable reasons that people who are experiencing homeless have for not declaring their homelessness in lots of situations. One of the representatives of those with lived experience used that word, and at first I found it a bit shocking. I don't disclose my homelessness to the people I speak to, whether they're people that I might just meet on the street or my doctor or whatever. And I think it's about the humiliation, the shame that's associated with homelessness, where it's a bit like blaming the cabin boys for the sinking of the Titanic. People feeling that they're at fault for being homeless. And I think that feeds into, at some level, the whole question of recognition. There's something really wrong with the way that gets internalised and projected onto people as their fault. So that's all. Thanks, Jane.
Thank you, and thank you to all of our our panellists for that really engaging discussion. I think, you know, there's so much to do. It was really good to get a sense of where you think next. We did hear yesterday, or with the tabling of the final report of the parliamentary inquiry into homelessness in Australia, one of the recommendations was to call for a housing and homelessness strategy, and let's hope that health and things like that are well in there, and let's hope the government accepts that recommendation. But Jenny, I've run over time, sorry.
Oh, you did pretty well, Jane. So look, thanks to you and thanks to all the panellists for a really vibrant discussion, and clearly there's so much more work to be done, you know, work that is long overdue and really has only just begun. But it's really good to identify through today's discussion where we should point for our next steps in trying to prevent this largely silent blight of premature and preventable deaths of those without a home. Again, I would like to thank our sponsors without whom this work couldn't have happened: Salvation Army, Wintringham, Micah Projects, Sacred Heart Mission, Bolton Clark, and Jesuit Social Services. Thank you all for being part of the launch. Thank you to our panellists, to our speakers, and for all of you for being here in this incredibly busy week. And we thank you for supporting Homelessness Week and look forward to seeing you at our next Council of Homeless Persons event.